Welcome back to part 3 of our conversation on TMJ, which is temporomandibular joint, and TMD is temporomandibular disorders, which is the pain associated with this area. So when we do talk about imaging, what we mean is how we're going to accurately look at the images. So we have the dental x-rays that are routinely taken, but we also have other x-rays or images such as CAT scans or cone beam or MRIs to look at the bony structures around the condyle or the little disc that sits in the TMJ. So we want to look at the position of the condyle. We wanted to accurately represent the pathology. We wanted to accurately represent the tissues. Are there any perforations or tears of the disc? And what movement are people having in the jaws? Or what lack of movement can we see that's occurring in the jaws? We need to look at the different surfaces. We need to look at the position. We need to look at the condylar shape, because sometimes people can have arthritic or cancerous kind of changes in the shape, which definitely needs to be dealt with. Different images are panoramic, which is what we call an OPG, and that's the general large x-ray that a dentist would normally take with the two little x-rays. And that gives us a good general overview. Sometimes these x-rays are taken so that then we can decide what is the next x-ray that is taken on our journey to try and work out what the problem is. A tomogram is a more specific kind of x-ray that looks at the jaw joint itself. You can take it from the side of the face, or you can take it from the front of the face, or you can take it from both, just depending on what needs to be looked at, because each image will give you a different view. A submento vortex is just a different kind of x-ray that can be taken. It's probably not one that's rushed to be taken nowadays. These are the newer kind of x-rays. I personally still like taking tomograms because they are just the basic x-ray, but they reveal so much information. And then from a tomogram, I work out, do we want a CT scan, a cone beam, or do we want an MRI image to be taken? So it's becoming a bit trendy nowadays to start taking these images straight away. I personally like taking the simpler 2D images and then see what they reveal before I will move to these more elaborate, expensive, but also more radiation type of x-rays. So the simple OPG or panoramic x-ray allows us to look at the teeth and bone around a tooth to see if there's any issues there. Are there any fractures of the mandible, which is the lower jaw? Where are the teeth? Are the teeth all coming through? Are the baby teeth falling out and the new teeth are coming through? Any medical disorders? And also just a general overview of what's happening with the condylar head, which is the part of the lower jaw that connects to the upper jaw, and that's what we call the TMJ. So looking at this x-ray, you can see that we've got this large lesion on the bottom down here, and this is what we call a panoramic x-ray or an OPG. This large area is destroying the roots of the teeth. It's entered the nerve space that's occurring down here. That's the mandibular nerve as it comes down through, and that's been diagnosed as a keratocyst. There are other things that an OPG can reveal. This is what was diagnosed as a mieloblastoma. This is a squamous cell carcinoma in somebody's jaw. And down here, there was a mucus retention cyst that was occurring in this person's. So an OPG is a great way, as a diagnostic tool to have a first look at everything. And like in this top x-ray, this dark spot here, it shows that there's a large hole in this person's tooth. They've got teeth that are decaying and broken down and just rotted off. And these dark areas at the tips of the roots are showing that they've got a large abscess associated with those roots that are just left in there. So what we have here is two different areas that can cause TMD. We have the muscles and we also have the joint itself. So if we're to have a look if it's a muscle issue, there are different types of treatment depending on what your problem is, but this is where Botox plays a part, because Botox stops the innervation of the muscles, so it stops the muscles working as hard as what they normally would, and Botox would give us a 3 or 4 month period. You can use coolant sprays, again depending on the problems. You can use medications, skeletal muscle relaxants such as Valium, diazepam or temazepam. Trigger point injections is applying local anesthetic to the acupuncture points. Splints, occlusal splints, is to wear at night time to not have as much pressure in your grinding and clenching. Occlusal adjustments is where we adjust the way your teeth bite, so we adjust the teeth themselves to put more even pressure. Or as I showed you in part 2, there's orthodontics where the braces, the orthodontics, puts the teeth in the correct position. Now if we're to look at the joint, you can see that we have the base of the skull here. We have the ligament or the disc that is attached by ligaments to the capsular space. This is the condylar head. So this is how the bottom jaw attaches or connects to the area, and the disc is connected by muscles, and so is the condylar head. So it's an exceptionally complicated area with muscles and ligaments and the disc and the bony structures as well. And if one of these tiny muscles or ligaments isn't functioning properly, the disc you can have problems and cause TMD type of pain. So there's a lot of different things that can be done. You can use medication, non-steroidal anti-inflammatories. You can use local anesthetics, steroid injections, which some people do but not used as much. Arthrocentesis, which is a surgical approach. Arthroscopy, and you have surgery where the disc itself or the jaw itself is repaired. These bottom ones, especially surgery, it's not rushed into because it's exceptionally unsuccessful. So only if we have to do we look at the surgery component of TMD. So if we're to look at a tomogram, this is the head of the condyle, this is the base of the skull, and this is what we call the eminence. So as we open up our jaw, the head of the condyle moves forwards over the eminence and ends up somewhere here as we open. So this x-ray here shows the jaw. It's moved from this position, from the fossa to in front of the eminence, and that's what it normally looks like when you open and close. This is a tomogram, so we can have a look at the shape of the jaw as well and make sure that everything's looking okay. So there's a lot of different things that we use to have a look at when we take a tomogram. Now, tomograms are taken for patients with TMD, medical disorders infecting the TMJ. Before we do any major dental work, it's normally good to take a tomogram to make sure that the condyle looks okay. Prior to orthodontic treatment for patients who have TMD issues, to make sure there's no major problems that can be seen. An AP view just means taking it from the front, and again we can have a look at the condylar head and the space as to what it looks like. Now this is what's called an anterior displaced disc without reduction. So here is the ear, here is the condylar head, so here is the fossa that the condylar head sits in, and this is the eminence. This is the bumpy bit that sits in front. So when this person opens, as they open their jaw, the condylar head should move here somewhere in front of the eminence. But as sometimes when people come in and they say, oh, my jaw is locked, I can't open my jaw, what has happened is the jaw opened, the disc came forwards, but then as the patient closed, the head of the condyle went back, but the little disc stayed forwards. So in this patient, because this is what the patient looks like closed, so if we look at the right hand side with the patient open, the head of the condyle should be here somewhere, but that's as far as the condyle can move because the disc never went back into position again. So as the person opens their jaw, they can't open wide because the disc is stuck. So the same thing happened on the left hand side, but it's opening up a little bit further on the left. So it's very important to diagnose this correctly because you do not want to be doing jaw opening exercises when you're struggling when your disc is stuck forwards, because jaw opening exercises puts more pressure on the disc. When you have this problem, you need to deal with it early because this is what we call acute, no different to having your shoulder put out. If you deal with it early, then you don't get all the inflammation, the swelling of the disc, the stretching of the ligaments. You don't get all those larger chronic problems which are more difficult to treat. So when someone's jaw is locked, I go in there and there's a treatment I can do where I can inject local anesthetic into the area. It's actually an easy procedure. We make you a splint to wear that brings your jaw forwards and holds it in a nice position so that the disc can hopefully move back into position. So this is another person whose disc was completely locked, because as they move forwards it hardly moved at all, but the problem happened on both sides. Here it is closed, and as they open, it should come forwards, but as this person opens on the left hand side, it's exactly in the same position as when they were closed. But after injecting the joint, there's the eminence, you can see that the disc has moved forwards, or the condylar head has moved forwards, and the same on this side. So we've been able to generate movement in this person's condyle and the disc, and this was a successful case where after a few weeks everything was moving nicely again. The issue is when somebody comes in and it's a chronic, where it's been stuck there for a few months or a few years. Now this is somebody who came to see me, and how they open up their jaw, they can only open it up say 8 millimeters, which isn't much at all. So you should be opening your jaw like 3 fingers width is something like 35 to 45 millimeters wide. So this is where the disc is stuck. This is immediately after the injection. So immediately after the injection, you can see the difference in the opening because the disc is now moving. And then 2 weeks later, we have nice complete movement of the jaw and the disc, and it's not a problem at all. The treatment this person needed was just to wear a splint at night times, because it was the stress of the clenching at night times and the stress of the daily life that was putting a lot of pressure onto those very tiny muscles. So this is another incident where there's the disc, there's the eminence. So as we open, it should come forwards, but in this case, as we open, it's in exactly the same position as when it was closed. The issue with this case is this has been like this for 12 years. So what we need to do, and the success is a lot lower when the disc is now probably damaged, and that's where an MRI I find becomes exceptionally useful, and you need it taken by a good radiologist who can look at the MRI and read it properly, and they will tell you if there is damage to the disc or not. So we attempted the same simple things where we injected the joint with the local anesthetic, a splint was given, Botox was also used to help relax the muscles, because if the muscles are spasmed, then there's no hope of anything moving. This patient was also told if we don't have success, then the next step would be referral for arthrocentesis to an oral surgeon. So it starts becoming complicated, but it's diagnosing the issue that is the complicated part. This is another thing that is under the banner of TMD, where the condylar head in 2004 looked okay, but in 2007 you can see that the front teeth aren't touching it at all. The bite is completely changing, and in 2004 the teeth were touching properly, but in 2007 they weren't touching properly, and the patient was coping with that, but it's when they were beginning to have pain with their facial structure that they went and sought treatment. And I know it's hard for you to look at these x-rays, but this condylar head should be nice and rounded. It shouldn't be flat. So what's happening with this person is they're having degenerative changes occurring with the disc, and so as that disc gets damaged and more worn out, the bite, the way the teeth bite together, start changing also. So an MRI provides excellent images for determination of disc movement or non-movement, and what problems are there with the disc. I like an MRI if I'm looking at the disc or the muscles, and that's what an MRI can look like. It just looks like a bit of a mess, doesn't it? That's why you need a good radiologist who can analyze these x-rays and give us a proper report as to what they see. So temporomandibular joint dysfunction is a collective term used to describe a group of pathological conditions affecting the temporomandibular joint, its associated structures and its functions. Associated structures can be anywhere from the head to the back or even the way you walk. That is why a team approach is so important for this, because it's not just looking at the teeth, it's looking at everything associated. And that's why, like on the first video, I stated quite clearly, we need to have a look who on our team can help with all the issues. Because the TMJ is one of the body's most active, essential and intensely loaded joints, the significance of dysfunction of the muscles responsible for the TMJ function and resultant pathology is critical. So this slide here is giving us a look at the disc area. So if the disc isn't moving, if the disc is stuck forwards, then the condylar head can't move forwards. And so injecting in this area is really the simplest approach to try and create some movement and some space for this disc and its muscles to move properly. Otherwise, we start looking at more a surgical kind of approach, and there's arthrocentesis, which is the clinical procedure of using a syringe to collect fluid from the joint capsule. There's arthroscopy to go in there and look at the disc, and then there's surgery to recreate the disc and the condylar head, etc., with again this not being an exceptionally successful procedure. So it's normally the last resort if it's going. So that's the end of this slide series. Thank you again for listening to me. We'll continue on the journey of these PowerPoint videos to help you realize what's happening with TMD. Thank you.